Uncertainty. Humans hate it. Medical uncertainty is what makes the beginning and the end of life such controversial topics in bioethics. I mean, Western healthcare is based upon the scientific process. We need to be able to experiment and replicate results in order to feel comfortable making a treatment decision. So, what happens when we can't make a predictable prognosis? No place in medicine seems as uncertain as in the cases of extremely premature infants. The conversation regarding neonatal ethics is truly the culmination of ethical dilemmas found in all biomedical cases. Shortly after being born, many neonate patients face death, either because of extremely low birth weight, extreme prematurity, or other physiological defects. In the absence of a certain prognosis, physicians are faced with life or death choices. Well, there have been very many influential cases since the 1980s that have shaped the conversation about neonatal ethics. As with other fields in bioethics, basic ethical principles guide the conversation. The ethical dilemma started in 1982 with the famous Baby Doe case. Baby Doe was born with severe Down syndrome and an esophageal defect. With Down syndrome, there's certainty of retardation within a predictable range. With extremely premature infants, there's no such certainty. All cases in neonatal ethics consider quality of life judgments and the best interest standard. Without medical certainty, these judgments are even harder to make. A lot of people would say that the conversation should just stop here, that quality of life judgments really can't be made that early in life. Well, the goal of neonatal ethics is to minimize the possibility of letting a baby die who could have lived normally, and aggressively treating one who will suffer, have severe handicaps, or die anyways. Quality of life judgments still must be made without predictive information, and that's why parents and physicians have such a hard decision to make during these first few minutes of a baby's life. The term viability has been coined in order to try to make this decision easier for parents and physicians. So at 23 weeks and 500 grams, an infant is considered too immature to survive. But at 25 weeks and 600 grams, the initiation of intensive care is warranted because there's a 50% chance that the infant will survive without severe handicaps. So viability tries to give a quantitative definition to this mysterious gray zone. But still, infants are born in the gray zone between the two boundaries of viability, or they have additional birth defects that make their prognosis more uncertain. Medical technology even has made it much easier and pushed the boundaries of viability so that an infant who is maybe 25 weeks but below the 600 grams could still survive. So this raises the question of what morbidities are acceptable. Well, the best interest standard is used for many patients nearing the end of their life, as we've read about, and it's been suggested to be used in neonatal ethics as well. But how can the best interest of a child who has just been born and whose future is uncertain be determined? To answer some of the questions that have been raised, a good starting point, I think, is to look at the basic guiding principles of medical ethics. It's a great place to start to answer a few questions that have been raised, but it definitely doesn't answer all of them. So the first principle is beneficence, which is kind of the foundation of medical decision making, and it assumes that the physician's role is to provide treatment that's beneficial to the patient. The second guiding principle is autonomy. And autonomy is the patient's right to make their own choices and have them be respected. Later on, we'll talk about a very influential case where this ethical principle was not followed and the patient's autonomy was not respected, and we'll see what happens when that occurs. Informed consent is a very important part of a patient's autonomy, and that is because a patient is assumed to not be able to make an autonomous choice without sufficient information about the prognosis and all the treatment options. So autonomy requires that the clinician provides sufficient information to the neonate patient surrogate in order for them to make that autonomous choice. And the third principle is justice. This requires that the physician provide treatment based on the patient's best interest, regardless of their race or their socioeconomic standing. The last guiding principle is non-maleficence, and that is, I think, the most ambiguous guiding principle. It assumes that the physician will do no harm, but this becomes controversial because what one person thinks might be harming an infant, the other person thinks might be helping them. And so that's why the decision-making process should always be open communication between a physician and parents, because values and experience will always shape and influence what one thinks is harmful or not. And sometimes those assessments of harm might be conflicting. So that's why it always has to involve the surrogate and the physician. The legal and ethical assumption is that parents would make the best surrogate for an infant, but parental authority is not absolute, and physicians do have the obligation to challenge the surrogate or parent's authority or decision if they feel that it really is very unethical. And so to continue, there's a couple strategies that have been proposed to help make the decision-making process simpler. The first one is called the statistical prognosis strategy. It involves actually withholding treatment for newborns who have unfavorable prognoses. So they don't even start the treatment or resuscitation. The wait until certainty strategy is the second strategy that's proposed, and that involves the universal initiation of aggressive treatment in the NICU until there's near certainty of death. The last one is called the individual prognostic treatment strategy, and that calls for the resuscitation of infants and a reevaluation of their prognosis and their improvement or lack of improvement after they've received treatment to its fullest extent. I'm going to just touch on the differentiation between withholding and withdrawing treatment in terms of neonatal ethics. So legally and morally, withholding and withdrawing treatment are considered equivalent, but in clinical practice, that's not necessarily the case. It really differs between practice because some physicians see withdrawing treatment, so after the initiation of treatment, withdrawing that treatment is seen as active euthanasia, and other physicians see the withholding of treatment at the beginning, so not even starting treatment, to be more morally unacceptable because they see it as not even giving the infant any chance to live. So now I want to talk about a few influential cases in the field of neonatal ethics. The first one happened around the same time, but a few years later than the Baby Doe case in the 1980s. So Sydney Miller was born at 22 weeks. And before she was even born, it was known that she would have lifelong handicaps and that she had a very poor prognosis of survival. So before she was even born, her parents and physicians agreed that the baby should die with dignity in her mother's arms. When she was actually born, the hospital administrator made the decision to initiate resuscitation in the NICU without asking the parents for consent. So what happened with that is that Sydney survived, and she was sent home with severe impairments, and she's actually still alive today. So this case shows what happens when the parents' expressed wishes are violated and when their autonomy is not respected. So some people still, this case today is still controversial because Sydney is alive, and at the time, and still in places today, survival is one of the many facts that's considered to be in the child's best interests. But she is living with severe handicaps, and her parents are worried about who will take care of her after they're gone. And so many people still see it as a very unethical violation of parents' wishes, while some people see it as the right decision and actually saving her life, and that just surviving is enough reason to resuscitate. The other end of the spectrum is another case where physicians recommended that the child die with dignity and the parents chose to receive the available care. So in this case, Nicholas Kahn was born at 25 weeks and 475 grams. And like I said, his parents ordered resuscitation, and Nicholas spent the first 6 months of his life in the NICU and experienced many complications. And as a boy, he still has many severe handicaps. So what this case brings to light is that a lot of people see the parents' choice here as causing Nicholas extreme pain and suffering for the first part of his life and possibly for the duration of his life. And this case actually led to the development of a conscientious objection policy for neonatal nurses so that they can refuse treatment when they think that it will cause the patient greater harm than good. So these cases happened in the 80s and 90s. There's still many cases like this today, and I think that physicians should always keep in mind the basic ethical principles of biomedicine when they're practicing and dealing with neonatal cases. And I think that they should be able to practice without fear of punishment. So for this reason, I think that legislation should not interfere with the decision-making process and risk compromising the patient-physician relationship that's so important for prioritizing the patient's best interests. Thank you.